Okay, starting with part two, and I left off yesterday's video at induction. I'm going to start with the video. It's actually called How to Wake a Horse Up Safely, but it does show a lot of the stuff that I just talked about. So I'll play it, I'll pause a few times, and then we'll get back into the PowerPoint.
My name is Ron Monsager. I'm the program director for the anesthesia division here at the University of Minnesota College of Veterinary Medicine.
And I'll just point out one thing, if you can see how big the fluid bag. So normally in small animal, we use a 1 liter bag of fluids. This is actually a 5 liter bag, which is a standard IV bag that we use.
The process of anesthesia starts with placing a catheter in the jugular vein.
And what I'll show you here is this horse had been sedated earlier, and this is where they've put the jugular catheter. Now, we don't do like normally how you tape around the leg of a dog. We're not going to tape around their neck. So normally it looks like they can put a little stitch here. We used to put a little dab of super glue and would stick it to their skin. And when we go to take it out, it just takes off a little bit of the hair. But that's how we secure the catheter. And then we usually have a longer line. So if we have to move away from the horse, we can still give drugs and not be super close. So what you're seeing now is they are giving some of the additional sedatives and they're getting ready to do the induction.
Neck. And then usually the next step is we'll give a small dose of a sedative to calm the horse down. We rinse the horse's mouth out with some water to remove any food material that they tend to have in their mouth so that we don't put that into their airway once they're asleep. And then once that process is done, we walk them into the induction stall, put them behind a padded gate, and let.
Okay, so this is where I was talking in the video and I was trying to explain to you what I was talking about. When you induce a horse, if you were at a farm, you would want to do it against a wall. If you do it in the middle of a field, they can fall either way and they can injure themselves. So what you want to make sure is this is called an induction stall and it has a gate. So you can see when they go to give the drugs, people are going to push on that gate. So when the horse falls, they fall straight down, and this padded wall protects so that they don't scratch their cornea or they don't fall and break a limb. And this is called a padded gate.
Calm down and settle in there. And then we give a dose of a couple of different drugs called induction drugs, which are given fairly rapidly intravenously. The horse is then rendered unconscious and slumps to the ground. At that point, we place a endotracheal tube into their airway. Endotracheal tube into their airway.
So what I wanted to show here, now this horse, this would be like in a dog you just gave the propofol and you're getting ready to give, to put, to intubate. Now, I will hold the mouth open for someone, but in a horse, their mouth doesn't open very wide. So this is a mouth gag, and what they're going to do, they don't show it in the video, so that's why I want to stop. They'll put it in between the mouth and they crank it open. And in horses, intubation is blind. So they're just going to pass an endotracheal tube very easily. Now, what they also do is take this towel and put it over their eyes, and they tuck it in the halter, and that'll help keep the horse asleep.
So it goes through the larynx into the trachea, and we use that to administer inhalant anesthesia, which keeps the horse asleep throughout the anesthetic period. Once the endotrach tube is in place, then we hoist the horse with the hoist system, place them on the surgery table, attach our various monitoring devices.
So what they did not also start to show is that in order to get the horse onto a table, they put hobbles, these strips. They put it right at the fetlock. So here's the hoof, here's the fetlock, which is like our carpus, and they put them on all four legs, and then they will put them on a hoist. I'm going to send you a couple other videos that you can watch on your own. They also have pictures in your book. So you can see they lowered the horse on a table. And what I want you to look at, and this is one of the questions that I asked on the discussion board, why is padding so important? You can see all of these surfaces here are all padded. So no surface of the horse should be touching a hard surface. Has to have some kind of padding. So they're hooking up the breathing system. You can see how large the breathing system is. What that white thing is, just like a block of wood. Normally we put some type of block so that the teeth don't compress the endotracheal tube. So some type of, right now they have the mouth gag still in, but you'll see the gag.
So that we can start assessing the horse's condition at that point. And then the surgery team, while we're doing that, the surgery team will prepare the horse for surgery.
So they're hooking up the
prepping
fluids.
Prepping of the surgical site.
There's the SpO2, there's the block.
The surgery suite, perform the procedure, and then roll the horse out, disconnect it from our monitors, and
those are the hobbles at the fetlock.
Stall, and let the horse wake up. We've got a new recovery stall that is equipped with a walkway that we can look down over the top of the wall and watch the horse and be able to hear.
So right now, this horse has already been extubated. They do have the block in the mouth. I cannot see, it doesn't look like the tube is in. They've left the towel over the eyes. Now, someone's not in here. Now, someone can probably get in here quick and pull that piece of wood out of the mouth and could pull that towel off their eyes.
Horse, as they're waking up, that's
watching breathing
than we've ever had before. And we also have a new recovery flooring system that consists of an inflatable air pillow to cushion and protect the horse until they're ready to stand, to hopefully greatly reduce any risk of injury to the.
Now that's not too bad. That horse is kind of like, oh, I mean, I've seen horses flail way worse than this. So this horse is kind of trying to get up, not waking up too fast. But the nice thing is with this padded floor, they're not going to injure themselves, and all the walls are padded. So if they run into the wall, everything has padding. Okay, nothing is a hard surface. But the nice thing with this is the University of Minnesota Vet School, is that's inflatable. And as the horse starts to get lighter, they start to put the air out. So then it has a flat surface. But when it's first asleep, it's inflated.
The recovery process. So as we watch the horse wake up, we are primarily looking at their eyes and watching for twitchiness in the eyes, or what we call nystagmus, where their eyes roll back and forth from one side to another very quickly.
I'm going to rewind it. I really want you to watch the eyes and the head.
Primarily looking at their eyes and watching for twitchiness in the eyes, or what we call nystagmus, where their eyes roll back and forth from one side to another very quickly. As long as we see that, we don't know the horse is, although sort of awake, is probably not going to be able to stand well on their own at that point. And so we wait until a lot of that is resolved and gone away, and then pull the plug on the mattress and allow the horse to have a firm foundation to stand upon at that point in time. We've put a lot of thought into how we've designed this.
So what you should have noticed, nystagmus is that lateral movement. A lot of horses wake up with that. Sometimes I've seen dogs and cats wake up with it, which it's more rare in a dog or a cat. It's very common in a horse. But you can see the head was going, It kind of reminds me of like a sprinkler. It's kind of like going back and forth. Luckily, that horse wasn't trying to stand, because what's happening is the eyes are trying to find the horizon. They're trying to find a fixed point in space, but they can't quite do it yet because they're not fully awake. If a horse stands up while they have nystagmus, they're going to try to follow their eyes, and that horse is going to tip the wrong way. So that's why he was saying, like, normally we don't want a horse standing while they have my nystagmus, and this is why sometimes post-op we give them sedatives like ACE or xylazine to keep them a little more sedated.
So that the horse can very quickly and easily be moved from the induction process to get them on the surgery table, wheeled into the surgery suite, perform surgery, then wheeled straight out into the recovery stall, making it easy for us to work on the horse and also make it good for the horse as they go through the anesthetic process from start to finish.
Okay, so there we go. So that horse, very, very quick, very, quick to wake up, not as quick as some. So that gives you an idea of some of the steps that I'm talking. Okay, so now that I've kind of showed you in the video, I'm going to talk about the different steps. And so remember, the difference between a horse induction and a dog induction is the speed at what we give the drugs. So a dog you give to effect, a horse is a bolus technique, ketamine, ketamine Valium. If we do use guaifenesin, a lot of large animal protocols add guaifenesin as a muscle relaxant that you can drip into effect. But most of the time, induction is very quick. Once we have them induced, and this goes for any animal you do, the first thing I do after induction is I put my hand on their heart. I try to feel a pulse and make sure my patient has a heart rate. Make sure I can feel a pulse, I can hear a heartbeat. So you want to check your vital signs first, then you intubate, and that should be very quick. And I just do a quick feel, get an idea, is it fast, regular, is it slow, are they beating, are they pink? Okay, let's move forward. Now, we are going to intubate, and then when we pad them, I want you on slide 16, this is very important. They have to have padding on all superficial nerves, so anything on the outside. And when they are in lateral, the forelimb that is closest to the table goes forward and the upper limb goes back. So they should be in a scissor position, okay? So the down limb is forward, the up limb is back. So we don't usually want them right next. You definitely don't want them touching. They definitely have to at least be parallel and somewhat separated. That is going to help circulation. So we need them padding, parallel, in a scissor formation. Now, if we just stopped here, most of these induction drugs only give us about 20 minutes. But we are intubating and we are putting them on inhalant. So the injectable wears off, the inhalant will kick in. If you were doing, in this scenario, if you were doing TIVA, which is a total, all of your anesthesia is maintained with intravenous drugs, that's when you would give a little bit depending on how long the procedure goes. But remember what I said in the other video, TIVA, where you're not using an inhalant and anesthesia and oxygen, TIVA is only for like procedures that are like an hour or less, preferably less than 45 minutes. If you're going to be longer than that, the horse should be intubated, should be on inhalant. So here's an example of what they do is, so they've got the hobbles, and very important, a lot of people are like, doesn't this hurt the horse? As long as you put it at the area just proximal to the hoof, that little indentation, which is the fetlock area, and then you're going to hook it up, and usually there's a mechanical hoist, and people will hold the tail and the head and will guide it. So you normally, the induction stall is like right next to the OR. It's not like you're taking a horse from here way over here. This is usually all very close together to make it easy to move the horse. And here's an example of some of the padding. So now you can see this horse. Let me point out something else that's strange in this picture. And these pictures are on your book. If you see, these are actually shoe covers. Normally when you're in an OR, we put on shoe covers. to cover our shoes. You still pick out the hooves, you still clean the hooves, but what you can do is you can put the shoe covers, and that helps trap any debris that's in their hoof. So now these are parallel, but see there's a pad in between them. These are pulled back, but there's padding. One thing that you want to be careful of is that, and there's notes here below, but if it's a dependent muscle, dependent is the down, gravity dependent muscle is the muscles touching the table. The weight of the top is going to push on the bottom. They have to be padded. You can see in this horse here, this horse is in BD or dorsal recumbency. That metal, these things hold the horse. Do you notice how the legs are kind of just laying there? When you guys do surgery in dogs and cats, we usually put ties around the limbs and we stretch out the legs. And they're stretched pretty good. In a horse, you don't want to do anything extreme. You don't want to put any pressure of ties, and you don't want to stretch and pull on nerves. So normally a horse is going to kind of just be like, their legs might be secure, but they're not stretched. Because again, if a horse gets light, you don't want them kicking. So they usually put something to hold them, but they don't overstretch that. So that is very important. In the video, it talks about IV induction. So padded walls. A free fall is if you do the horse in like the middle of a field or the middle of a stall and you just let them fall. But normally we like to put them up against the wall, either with people pushing on the horse or in that stall, they have the board that goes up against the horse. Okay. So we want sedation quickly because we don't want trauma to the horse. We don't want any trauma to people. We do a bolus. If I ask you what drug is given to effect in the horse, it is guaifenesin. All of their drugs are a bolus technique, intubated, check the vital signs, and then we hoist them. Now, let's talk about induction. This is not common, but if you want to put a tube in the trachea, this can be done on foals. This is not done on an adult horse. You can place a nasal, it's a nasal tube, but it goes to the back of the trachea. And it doesn't go down to the lungs, down to the bifurcation. It just goes into the trachea. And then you can turn on the oxygen and inhalant. It's the same theory as if you do a mask induction. Now you can try to mask induce a foal, but I'm telling you, they look little and cute. They're extremely strong. A foal it's gonna be very hard. The problem is inhalant inductions aren't typically done in horses because of excitement phase. So normally it's gonna usually be intravenous induction is the safest. But if you're going to do a foal, you can, and this is kind of used typically on sick foals. Maybe they aren't going to give you much of a fight. Other than that, so you put the oxygen and inhalant through a nasotracheal tube, and they inhale their induction. And then you can leave it in, and that will maintain induction. But let's talk about the traditional intubation. So, and if I did not stress it enough, like I'm thinking back to what I told you about small animal. If I didn't stress it enough, when I choose an endotracheal tube for my dog, I usually pick the one I think I'm going to use, one bigger, one smaller. I like 3 tubes out. But you should at least have a couple different tubes with different sizes. Now, the highest size we use in a dog is usually a 14 millimeter endotracheal tube. We can go up to 26 millimeter, and that's diameter on a horse. So of course the tubes are much bigger. You need some type of mouth gag to open their mouth, a 60 mil syringe to inflate the cuff, and then you have to pull the tongue and slide the tube in. So gauze, I mean their tongue is very slippery. They're technically, since they're an herbivore, they have a lot of saliva. So here is a picture of their tubes. These are the silicone tubes that talked about. This is PVC piping, and they just put some bandage material around it. And again, this cuff is large. If you could use a 12 mil syringe, you're just gonna be sitting there forever filling your cup. So you want to have a 60 a 60 cc syringe. Okay, so selecting a lot of this, most adult horses are going to be 22, 24. The bigger horses are probably 26, upwards of 30. Now, a foal is usually going to use between a 10 and a 14. A foal is going to be similar to like a very, very large dog. So maybe a 12, 14, 2. In dogs and cats, I remember I talked about we don't like a lot of tube, which is dead space sticking out of the mouth. So, but in a horse, luckily their neck is very long. So normally you can pretty much almost put the whole tube in because you're not going to be able to feel. I tell you to feel the trachea. We don't want it to go past the bifurcation. Well, you're not going to be able to feel in a horse's neck. It's going to be extremely difficult. So normally you just pass the tube and then you're going to tie it in. Okay. So you check your tube, make sure your cuff is good, make sure the tube is clean. Orotracheal intubation is the standard, go through the mouth into the trachea, orotracheal. And it is blind, and it says by feel. When we've intubated horses, nobody's ever really put their hand in their mouth. When I mean feel, it's like, does it slide in? Okay. So normally we just pull the tongue, slide the tube, and then usually someone goes and pushes on their chest and you feel for air. That's how I check a tube in a horse. Okay. You can look for fogging in the tube and you can see if your bag is moving when you hook them up. But if you want to know if the tube is in right after intubation, someone just goes and pushes on the chest and feels for air coming out of the tube. Okay. So we slide it in, extend the head, put it over the tongue. You shouldn't get resistance. If you start to push in the tube and you feel like you're hitting something, usually you just back up, move it, and twist. So you kind of just try to keep, you don't want to shove too hard because if you hit something, you may just have to back out. And normally we tie it to the halter. We don't usually do the big tie over the muzzle like we do in a dog, or you don't do it usually behind the ears. That's really long. Normally we just tie it to their halter. And then you inflate the cuff. Now, occasionally you have to do what's called nasotracheal intubation. Now, this would be you give all your IV. This isn't the same nasotracheal I just talked about in the foal. That was nasotracheal induction. Now this is nasotracheal intubation. So you give them their bolus, but instead of passing the tube in the mouth, you're going to pass it through the nasal cavity. But if you're doing something to the head or the neck and you don't want a tube in the way, we usually use this technique. Okay. So it's going to, and then the landmark is the ventral nasal meatus. So that means we pass it low on the nasal cavity, ventral, and medial, and it should slide back with no resistance. The only downside to this nasotracheal technique, and again, orotracheal is the most common that you're going to see, but is epistaxis, which is a bloody nose. So obviously the nose is sensitive. You have a tendency to cause some bleeding. Could have some abnormal anatomy. Miniature horses are harder to intubate, and a horse with laryngeal paralysis. But I would say overall, if someone said, what is the easiest species to intubate? It is a horse. By far, they are the easiest. One of the most difficult, a rabbit or a pig. So if I was ranking from, I mean, cats are difficult, but a rabbit, their mouth does like barely opens. So it makes it a little more challenging. Okay, so what we're going to do, you've got them intubated. Oh, let me talk about verifying the pulse. Because if you can't, a horse has a very big thorax. You can try to put your hand over the thorax. You can try to get a stethoscope. But a horse has what's called a mandibular artery. If you look at their big cheek, that's the masseter muscle, and then they've got a bone under their jawline. If you put your fingers here, and sometimes you can feel your own, there's a little pulse in the jaw. So sometimes on a horse, if you can put your hand there, you can feel for a pulse. Okay? So verify the pulse, we induce them, then we're going to put them on the inhalant. So usually I start, if I'm on isoflurane, I start somewhere in 2 to 3% isoflurane. If I'm on sevoflurane, I might start anywhere from 3 to 5%. It's just going to depend on how deep they are. The other thing to keep in mind is that when they're on an inhalant, and you want to turn them up or you want to turn them down, it's going to take a while for them to come up and down. There's a lot of there's a lot of drug to increase or decrease concentration. So when you go to turn them down or turn them up, it's not going to be instantaneous. It's going to take a little bit to change. So one thing that happens if you have a horse and they're getting light and you want to turn them up, you may have to give them, now it says thiopental, which we don't use anymore, but you could give them some ketamine Valium, you could give some xylazine ketamine, and you can give a little bolus of that to bring them back under. Again, especially if they're moving. Okay, so just realize if a horse gets light, most equine anesthetists are going to have some drugs in their pocket. You need to have access to intravenous agents at all times because you don't know when you're going to need to get them under. Because if a horse gets light, it can be very dangerous. They start kicking. We got to be really, really careful. Okay, so now they're under anesthesia and we need to monitor them under anesthesia. One thing is, I've told you guys this term. I'm always going to be referring back to last term's material. We talked about monitoring last term, and so you should kind of have an idea of what normals under anesthesia. A horse is already going to be more prone to hypoventilation. They don't breathe as often, and they don't breathe as deep. The other issue that I told you, when you have a horse, whether they're on their side or on their back, there's a very heavy intestines pushing on their diaphragm. So I take a horse and I make them respiratory depressed. They're not going to breathe as deep, and then I'm going to put a whole bunch of weight on them. So this is tended, we see this more when they're in dorsal than lateral, but it can happen to both. And I just want you to know what hypoventilation means. And by now, you should be able to tell me hypoventilation is low respiratory rate and low respiratory depth. How do I treat that? Because to me, you could regurgitate that to me on a test. But if you had an animal under anesthesia, you have to troubleshoot and figure out, okay, what I'm going to do in this situation, I'm going to try to turn them down a little. Sometimes that gets them breathing deeper. But in a horse, what I told you is that I'd probably say 99% of the time, a horse in an OR is going to be put on a ventilator. And that's going to fix the hypoventilation because the ventilator, CPPV, continuous positive pressure ventilation, is going to breathe for the horse. And remember, CO2, 40 is normal. So I'm going to watch. If my CO2 is 50 or 60, I'm going to increase my ventilation because the way to get rid of CO2 is to ventilate more and deeper. If my CO2 is in the 20s or 30s, that's too low. How do I treat that? I back off ventilation. If you don't breathe as often, CO2 is going to creep up. So again, how do I treat CO2 that's going one way or the other? Now, hypotension, which is low blood pressure, I've always told you that the mean arterial pressure should not be below 60. But in horses, they do not like it below 70. And remember, that's mmHg, millimeters of mercury. So they are prone to low blood pressure because part of it is the weight of the horse on all of the blood vessels. The anesthetics, they get cold. So to remember, how do I treat hypotension? You can try and turn, because I will tell you the most hypotensive agents that you use are your inhalants, your isoflurane and your sevoflurane. Now, propofol, we don't really use in horses, but that can cause hypotension. Alfaxin can a little bit. But your inhalants are really bad. Acepromazine causes hypotension. So I said, how do I treat that? First thing I try to do is I try to turn down my inhalant. Second thing is, can we give a IV fluid bolus? Because if I have low blood pressure, a lot of times in anesthesia, it's because we dilate the vessels with the drugs. If I'm a vessel this big and I make it this big, automatically the fluid in here is under lower pressure, therefore hypotension. If I give fluids, I boost the volume and I increase the pressure in the vessel. So I want you to remember these numbers. Now, what is hypoxemia? Low oxygen in the blood. Horses that are in dorsal, pregnant, a really bad colics tend to be hypoxemic. Now, remember on this slide it says PaO2. Remember when you see the A here stands for arterial. So on a blood gas, if we were to take an arterial sample and the oxygen was lower than 80, I would be concerned. But remember, normally we're using a pulse oximeter, and that is SpO2, which is partial pressure of oxygen. So SpO2 should always be greater than 95, okay? So if it's PaO2, it's 80 or higher. If it's SpO2, it's 95%. And then what that tells me, blood pressure and oxygen tells me if they're going to get blood to the tissues. But this is big, okay? I stress this. Horses are at high risk for myopathy. And that is where we have a lack of perfusion to the muscles. And sometimes that happens because of low blood pressure. But a lot of times what happens is myopathy is because they are laying on these muscles. We do our best with padding to help, but they're always going to have a chance to have myopathy. And remember, another way to say myopathy is tying up. If the muscles, they get kind of constricted and tight, hypotension is just going to make that worse. So we have to monitor. Now, in the video, if you caught it towards the end, she actually was putting a blood pressure cuff. Now remember, there's NIBP, which is non-invasive blood pressure. And let's see, let me put, I think I can type this, you can see it on the video. So if you can see it on the screen, and hopefully you can read that when you play this video, your NIBP is non-invasive blood pressure. That is a cuff. And that is an automatic reading that you get. If, and that would be, you can set it to read every minute, every 5 minutes, every 20 minutes. Most often, anesthesia parameters are monitored every 5 minutes. So normally you would be setting the machine to automatically inflate every 5 minutes to give you a reading. Now, something called IBP so the better blood pressure monitoring is what's called direct blood pressure. And what you do is you actually take an IV catheter, and we're going to put a catheter in an artery. What we're looking at here on this picture is we've got a facial artery right here under the jaw. It's really kind of the submandibular, but so what they've done is this horse is in BD, you clip the site and clean it just like you're doing an IV catheter, except when you put in a catheter, you're putting it in an artery. We hook it up, and this one's called the transverse facial. It's right here. And then this one's in the dorsal metatarsal artery. So if you were working on the head or neck, you could put one in the back leg. Now it's hooked up to this little white cord, and there's a little piece in the middle. This is called a transducer. And this fluid line is hooked up to a pressurized bag of heparinized saline. So what happens is, remember, an artery is pushing out. When you put a catheter in the artery, blood is going to try to come out. I have a line under pressure, and I hook it up to the transducer. So what happens is, these aren't IV fluids. They're trying to push into an artery, and the artery is trying to push against the fluids. Well, the transducer picks up the pressure of the blood pushing on the fluid. And then that gives us a little pulse wave on our monitor. If you're going to work with horses, this is the gold standard. You're really going to do direct blood pressure monitoring for two reasons. It's the most accurate. Second reason is, I told you in horses we like to do something called a blood gas. It tests for their pH. It tests for their oxygenation status. And when we do a blood gas on a horse, we can draw out of this catheter, because remember, when you do a blood gas to check oxygenation, you need an arterial sample. Well, if this is already hooked up in the artery, there's a way to hook up a syringe and take a sample. So the nice thing with this system is that I can run blood gases plus get a much better information for my patient. Okay, now you're going to do your standard CO2 monitoring, blood pressure, respiratory rate, heart rate, temperature. But remember, the next slide that I'm talking about is the difference in how do we keep them asleep. So I just talked about intubating them and putting them on gas and putting them on the ventilator. That's if they're in the hospital for a critical surgery, a long surgery, and you need oxygen support. But you can do TIVA, and TIVA is there less than an hour. And this is in the field anesthesia. You are going to keep them asleep using intravenous, no tube, no oxygen, no inhalant. So a combination that we tend to use is guaifenesin, ketamine, xylazine. Ketamine, xylazine, or xylazine can be with romifidine or ditomidine. But what this does is it's going to combine into something called the triple drip. Now there is also double drip, but the most common induction agent is something called this triple drip. And it has all three. The nice thing is you get good blood pressure, which equals good perfusion to the tissues, not a lot of respiratory depression, but because ketamine is in the mix, they tend to have a little more blinking than they would with some other drugs, but we expect it. If you need to keep them asleep, because your doctor is either going to be able to do everything on this protocol. Maybe they can get everything done. If they can't, then you can give a little more ketamine, or you can give a little more xylazine, you can keep them asleep. So this is Tiva, and let me see if I can get this video. 1 second. Okay, so I have told you guys in the past, I'm not a huge Dr. Pol fan, but this is kind of a good example of field anesthesia, and they are going to be anesthetizing a horse for castration.
Archer is a rescued Arabian stallion who's dangerous to handle. These horses, they get governed by hormones only. If they are full stallions, you cannot turn your back on them. Oh, it's okay. It's okay. Dr. Pol has to sedate Archer to handle him safely.
Self-defense. Lady rescued him. He ended up just in the wrong hands with a bunch of other stallions, low man on the totem pole. Slowest he's ever backed out. Easy. Good boy.
Kareem wants to castrate Archer so he becomes more docile.
There, nicely on the high, dry spot. The very first year that I came here, 30-some years ago, there had not been a veterinarian for many years that castrated horses. And I remember in that summer, I castrated probably 60 horses.
Another shot knocks him out for the procedure.
When I gave the second, in that summer, I castrated probably 60 horses.
Okay, if you look at the horse in this picture, now, so this is field anesthesia. This is Tiva. The horse was given an IV sedative in the trailer. He is sedated but walkable. And you can see this horse has a lowered head, ears are down, legs are somewhat apart. And this, they're doing a free fall technique. This horse is just going to fall in the field. So we're going to watch. He's going to give the induction bolus. So the pre-med was in the truck. And it looks like he's not putting in a catheter. He's just hitting a vein and giving the drugs.
Another shot knocks him out for the procedure.
When I give the second shot and the horse will lay down, I tell people to get out of the way. We have no idea which way they fall. Okay, everybody watch out, step aside. But the horse falls sideways. And that's why I am in front. I'm hanging on to him. And tell people, stand behind me is the best. That's the safest.
Go to sleep.
Yep. Calmest this horse has ever been.
There he goes. How long have you had him?
I've had Archer for a week. They didn't have any money to castrate the horse, and he just needed it.
What's the saying? Take the balls out so the brains come back?
Shut up, Joe. There's a lady here. Yes, you take the balls out, the brains come back. And it is true.
So it's interesting. You know how I keep saying cats are like small horses or vice versa? In horses, they do a scrotal castration technique like they do in male cats. So it's interesting. They don't do it like a dog.
Oh, God. Looks like very uncomfortable.
If you've never seen a castration before, it can take you aback.
It's making me cringe.
I cut through the skin the whole time. I get the testicles out, and then I cut out the skin in between. It's squirting.
Oh, disgusting.
Did it get you?
Yeah. And that'll just heal up on its own?
Always does. A horse like this, 1 day rest, and he's a little sore. He doesn't fight this hard. So work with him, break him, and make a horse out of him.
There you go.
I learned that just let them get it by themselves. If they have their feet underneath them,
Oh.
they don't fall, they don't hurt themselves. When they get up, they're ready to get up and they walk away. Okay, you think it's your walk?
I don't know. A little unsure there. Like, okay, where's my feet? What happened? Easy, buddy.
I told Corinne after the castration, she'll see a big change in Archer. He'll be much easier to deal with, and he'll be a good riding horse.
Oh, I want to go home. He'll change his head because the hormones are gone. And then,
Okay, so you could see in that video, he was starting to wake up. They were being really cautious with the way that he was moving. That was an example of an IV technique done in the field. No gas, no tube, no oxygen. They did it in a big open area, helped control him till he got his feet under him. And one injection was enough. So sometimes you don't have to redose them. Now, if you're in the hospital, we're typically doing the injectable to an inhalant, which what we do is they'll give them the first bolus and then they will add in triple drip. And what happens is they give the bolus, which is some of the triple drip, and then they can continue to keep the triple drip going, even with the inhalant to help keep them. We use less inhalant if we keep using the triple drip. You can even give some lidocaine or detomidine to decrease your inhalants, okay? But the big thing of this lecture that I've been trying to tell you is that we have two ways we're going to do anesthesia on these guys. We're either going to pre-med them, catheter, bolus induction, tube them, anesthetic, or in a field or in your hospital in field technique, you might give an IM and an IV induction or an IV and IV chemical restraint, keep them standing, or TIVA where you keep them asleep with just IV agents. So you need to know the examples of those that I used when I talked about it in class and what situations we would do that. Now, big things when we talk about anesthesia in these guys and positioning. You don't want to stretch their legs. They absolutely have to be on padding. We want to protect their eyes because in a horse, the eyes are more lateral, and if a horse slides, we don't want them to scratch the cornea. So we have to control the head. Put on the hobbles near the fetlock, so those have to be put on properly, and they have to be padded. And if I ask you what happens if we do not pad them, neuropathies, which is pressure on a nerve, and it can cause temporary or permanent nerve paralysis. So that horse can wake up limping and stumbling. We have to be very, very careful of that. So I've stressed it enough. Pad, and then a neuropathy or a myopathy is just where the muscle, there was pressure on the muscle, and there was pressure and it decreased blood flow to the limb, and the muscles get tight or they tie up and they can get hardened, and the horse can limp, so you got to be careful. Now, recovery, the biggest thing we worry about is they want to stand up right away. It is built into their DNA, physiologic need to stand as soon as they think they can, which often they cannot. So you have your only option, if you have a horse that's trying to stand up too early, you're not going to be able to hold them down. Now, one technique in horses that people do is they put their knee on their neck and they hold their halter because what a horse does to stand is they take their neck and they throw themselves and help themselves up. If you control their head and neck, they're not usually able to get themselves up. That might work when they're first asleep and a little excited, but the problem is if 1,500 pounds wants to get up, there's not going to be a whole lot that your little body is going to be able to do. So the best thing to do if they're waking up too fast is to give some sedation to keep them sedated longer till they can wake up more appropriately. They have to be able to breathe through their nose, so they can't be up against the wall or in a if they're in like a pile of hay and a bunch of hay is up against their nose, once you pull the endotracheal tube, they have to be able to breathe through their nose post-operatively. So you have to make sure there's no mucus, no debris. Be very careful. Padded rooms, and this again, this is very dangerous. But your key is you don't want them standing too soon. So how do we start recovery? There's a couple different, in that video, the first video I showed you where they had the horse in the padded stall. Nobody was in there. Nobody had any ropes. But the other thing that you could do is put the halter on, and you can do what's called rope assisted recovery. You tie a rope to the tail and you tie a rope to the head or the halter. When the horse starts to stand, one person pulls on the tail, one person pulls on the head. You're trying to help the horse stand and not stumble. If each of you pull on a rope, you create equal force. You're going to help give the horse a way to stand up. And that's what's called rope assisted recovery. Now let me show you the picture while I'm on it. So here's a horse and they've tied it to the tail and tied it to the halter. Now when that horse starts to try and stand, everybody pulls. Now these ropes go through a hole, so you're not in here standing, you're outside, because really, again, they don't really want anybody in this recovery room. And then you can see this horse is now standing. So the rope's here, the rope's here. Here's an example of what I was talking about is now this is a miniature horse. So this is, you can control the foal and you can control, but the best way to restrain a horse if it was on the ground is you put their knee in the back of their neck. The trachea is here. So she is not pushing on the trachea. That's why you go in the back of the horse's neck. They have a strip of muscle there called the nuchal crest. And that's where you want to put the knee. And then you hold the halter with your hand. So that horse can't throw themselves up in the air. They can't get themselves standing. Okay. Now, the other thing that you can do on recovery, say for example, you had a horse that had respiratory distress, or they had low oxygen, or they had some type of nasal plugs, like mucus plugs. You can place a nasopharyngeal tube. So what you do before the horse is awake, now they still have an orotracheal tube, but you can take a smaller tube and you can put it in the nasotracheal area, nasopharyngeal. And so what it does is it goes in the nose and it just goes to the back of the throat. It does not go into the trachea. And you can hook that up to oxygen. And you can do that, and you can use something called a demand valve or an insufflation valve. Let me show you, I think, in this. There's not a picture here, but what it does, here's a horse that they've got the towel over the head. Remember I said they tied it around the tube and tied it to the halter. So what they've done in this horse is they've put this in the nose, they've tied it so it can't come out, but this horse can wake up and it can start chewing because, see, there's no endotracheal tube. So this, like again, we do a nasopharyngeal tube if they're having a hard time breathing during the procedure, they have low oxygen, or we're worried about nasal blockages, then we would put this in. And they can actually breathe. And an oxygen demand valve, what it would look like is, and I think there's a picture in your book, there's a green oxygen hose and there's a button and it hooks up inside that tube. And if you want to give the horse a breath, it's almost like hooking up a flush valve directly to the endotracheal tube. There's a button and you hit it and it, so it gives them little bursts of oxygen, okay? And it's like bagging the patient without a bag. It's kind of interesting. But again, this is just a technique if the horse was critical, had low oxygen, had breathing difficulty, you can put this tube in. Again, it's in the nasopharynx, so this horse can lick and chew. It's not going to damage the tube because it's going in the back of the throat. Okay, so I talked about this, talked about how to recover them. You're always going to want to be near the head when we're first holding them. You're going to watch the IE ratio, take the pulse every 5 to 10 minutes. When they start to swallow 3 times, you're going to pull the tube, so that's standard. The big thing that I'm looking for that is cautioning is nystagmus. If they start having the nystagmus and they start paddling, these are like not good signs. This is signs that my horse is potentially going to wake up too quick. So in this situation, the doctor might give more xylazine, or the doctor might give acepromazine and give a little sedative. And you can go in there temporarily, if your doctor says, and try to control the head. But if they start moving too much, they're usually going to just get people out of the OR. They're going to say, look, we need to leave. We need to get out of the OR. Things are getting dangerous. Let's see. Okay, so how we begin extubation, same principles. We see chewing, we see swallowing, we might see ear movement, eye movement, tail twitching. You want to deflate the cuff and pull it in one swift motion. And like I said in small animals, when you pull the tube, you need to at least monitor for 5 minutes. Make sure, and what are you looking for? Can they maintain a normal respiratory rate and a normal effort? When you take their tube, you're taking their airway. They have to be able to breathe on their own. And make sure you feel in front of their nose. Can they breathe? They have to be able to breathe through their nose. So ideally, what we're looking for is they extubate. In that video, you saw that horse go from on its side to sternal. And after a few minutes in sternal, they stand up on their own or with tail ropes, and then they walk back to their stall. What we don't like to see is where they're trying to stand during nystagmus, and we have to either sedate them or physically restrain them. And the worst outcome that we would see is we have a horse that actually fractures a limb. Because more often than not, if they break a leg, they're probably going to be euthanized. When a horse is standing, and you feel confident they can go back to their stall, we usually bring them back. They typically will have what's called a basket muzzle on for the first maybe 1 to 3 hours. What this allows is they can put their head in their bucket and they can drink water through the muzzle, but they're not able to grasp food. The big thing, we don't want them trying to eat bedding. So there is straw, which is that yellow stuff, and we usually put that in a stall and they sleep on it. And then they've got the nice green alfalfa hay. But a lot of times right after anesthesia, a horse is going to come in there and they might try to eat the straw, which is not nutritious for them. So we want to wait. They can have free water. After about 3 hours, we can try to feed them. And then you want to watch the patient when they wake up. If we're worried about a neuropathy, a nerve injury, what are you going to see? Droopy eye, droopy lip. A lot of the pictures in the slides and in the books, they show you horses that are anesthetized and they all have a halter on. But we usually took off their halter if they were going to be like laying on their side, because say you have the buckle of the halter, and here's the facial nerve. If the buckle and the horse's head is laying for like an hour and a half, 2 hours, it puts pressure. The horse's, their eye might be droopy, their lip is droopy, and that would be neuropathy. Radial nerve is near the radius. Can they extend their limb? Can they move their limb? So you're going to want to look for all of that. And then what is a myopathy? Again, muscle disease. Muscle is swollen. They walk very stiff. So you want to look for, if I say, what do we look for in the post-op recovery period? Someone's like, make sure they're doing okay. I'm not accepting that answer. I almost want to take, if you put that answer, I almost want to take off more points than the question is worth. Okay, you're going to look for myopathies, neuropathies, and colic. And how do we know a horse is colicking? If they're experiencing colic, most of the time these horses are rolling in their stall. They're rolling back and forth. They might be biting or kicking at their abdomen because their belly hurts. Now, one clinical sign sometimes people tell me is lack of gut sounds, but I'm wanting to know if I was walking by a stall, not walking in and listening, but if I just looked in a stall, could I tell a horse was potentially colicking? If they're rolling and they're kicking at their belly, biting at their belly, reluctant for you to handle them, especially in a horse that's been very sweet, all of a sudden they don't want you near their belly. These are all signs that maybe a horse is experiencing colic. So the big, I don't want neuropathies, I don't want myopathies, you don't want colic. Those are all kind of the big things to watch out for. And what I'm going to do, I'll end the video here. I'm going to find a few more videos that we're going to be talking about on Friday for review.